Hi, good evening to everyone. Thank you for joining me for this spontaneous discussion with Dr. Shankara Chetty. I'm just waiting for him to join. And so, in the interim, I thought I'd just share a few updates as to what's coming up, what I'm trying to see if we can get doing, what I want you to join. But as I was saying, this is an important discussion. Dr. Shetty has always been at the forefront of what's happening with regards to COVID 19. So in early 2020, he faced the pandemic full on. He took the risk himself personally and he dealt with it, understood the principle about the eighth day, and was able to help thousands of people in South Africa and across the world. This time it's a little bit different because he got on well. And that's what we're talking about. So for one, it's unusual for somebody to come and share their experience like that, but it's important. And what we'll be doing today is a clinical dissection of what happened, trying to make sense of it, and trying to see if we can find a way to explain it. Before I bring Dr. Shetty in, just to mention that in the description below is our newsletter. Click on it. There are lots of topics that you can look at. We've done a number of them now, beautiful imagery from Lumientia. And so please click on the link to join our newsletter. Additionally, coming up in another few days, next week, Tuesday, I'm tackling this one here for Celine Dion. She has just recently done her documentary. So I'm going to analyze it, look at it, and try and determine the question about spike autoimmunity. This is really what I've been looking at from a research point of view. So please, if you're interested, again, look in the link below, register, and this should be of value to anyone who potentially has had any kind of issue like that in the past. So let's see if we can get a Dr. Shetty in straight away. Hi, Shankara. Glad to have you here.
Hi, Philip. Hi, Philip. Nice to see you. Nice to see you again.
Excellent. You look exactly the same.
No, nothing's
Yes,
changed.
nothing has changed.
We've been
So,
through
as
a
I
little
was
bit of
explaining,
rough ride, but
yes,
we
yes,
made
yes.
it
So,
through unscathed.
I was explaining to the audience that this is
Yeah,
an impromptu discussion. We were
yeah,
talking yesterday about what happened, and I said, Shankara, this is valuable to share. And Shankara, being Shankara, he's quite willing to discuss anything in relation to health and so on. And so we're going to try and just look at it clinically, try and analyze what we think was happening, and see if this could be relevant to anyone else. So, Shankara, just so people understand, share a little bit about yourself and what was happening in the run up with regards to this specific period of time where you were unwell, ended up in intensive care. This is what, just a few weeks ago, isn't it?
yeah. 3 weeks ago.
3 weeks ago.
Three, uh, 3 weeks ago, Philip. Look, I think, I think the audience already, Philip, is well aware of my, if we can still call it a theory behind what happened during the pandemic. I was always of the opinion that it wasn't the virus that was causing the problem, but more a pathogenic protein. And in that first wave, the very sudden trigger of such a severe decompensation by a human being led me to formulate a theory on the possibilities, one of them being hypersensitivity and that kind of sudden response to things. But I think hypersensitivity was a diagnosis meant to inform treatment options, treatment plans. Where do we go? How do we negate what happened? But from the start, my look was always in an immune direction. And why I thought that, Philip, very vitally important, I think it's an area lacking in medical science. But from my perspective of being a natural science biologist and understanding more the interactions between the microbiology, the biochemistry, the genetics, and all the other nuances of the entirety of life, I realized that our immunology is the most important thing in anything. Now, if you look at everything around us and how it survives, you got groups of cells exposed to their local environment They are only contacted by those cells. They communicate in specific ways. They serve particular functions. You get those cells exposed to the outside that have to be able to replace themselves, exposed to different elements on the outside, so constantly changing environment. Their immunologic response will be different and governed by many different things. We do understand that cells have a surface, a glycocalyx. The glycocalyx is to always be thought of in identifying different cells. The glycocalyx of a muscle cell is different from the glycocalyx of a heart muscle cell, is different from the glycocalyx. So we use it as identification, but I think we must also remember that the glycocalyx of a cell is involved in cell to cell communication. And so these bodies of tissues talk to each other as individual cells through these glycocalyx. Just the reason I bring in that context, Philip, the spike protein from the beginning is what I fingered as the pathogenic protein of this illness. And yes, in the first wave, I saw that it managed to trigger what typically looked like a type 1 hypersensitivity reaction. And the typical treatment of that type 1 hypersensitivity reaction negated the problem very timelessly, almost miraculously. And there were no sequelae, there were no long term COVID symptoms. So it seemed like in that first wave, I had addressed the completeness of the underlying pathology. But then we got into the second wave of the illness. And in that second wave of the illness, I saw the clinical presentation change. I saw that it took longer to get these patients to recover. I realized that the 8th day seemed to remain the same. So the sudden event on a particular day never changed. It was never a build up to the 8th day. It was the sudden onset on the 8th day. And
Can I,
that
can I,
seemed not to change.
yeah, can I come in here, Shankara? Because I think it's probably important to highlight to people that this sudden change, as you said, is very characteristic of there are only a few things that do it, especially in
Right.
terms of the lungs. One
Exactly.
of them is acute left ventricular failure, where the lung gets full of fluid quite quickly. And the other one is mast cell degranulation, like an allergic.
And one other, Philip, which involves mast cell degranulation as well, is the sudden inappropriate immune response to a toxin.
Yes, yes,
Will trigger the
that's
same
right.
kind of mast cell
Same,
degranulation. The
which is
reason
yes.
I looked at cardiac failure creates a very particular kind of crepitus in the lung. And when you listen to a patient in cardiac failure, you hear those crepitations. It's a bubbly, crackling sound in the lung. And what removed that as a differential diagnosis was the lack of sounds in the lung. And of course, no pedal edema, none of those, no third heart sound, none of the things you would expect to see with a heart failure. So I'd say in those first and second waves, Philip, my view was quite cemented that I'm dealing with an immune response.
Yeah.
And of course, at that point, when we got to the third wave and we started to see the clotting issues, again, the standard intervention for a type 1 type of immune response negated the problem. No one died in my hands. But I noticed that I needed higher steroids. I needed a longer duration to treat these patients. These patients, unlike in the first phase, in the first variant, where the illness was restricted in its initial presentation on the 8th day to the lung itself. There
Mhm.
was no kidney issues, there was no other issues. When we got to the third phase, it presented with gastrointestinal symptoms, with if not treated, became coagulation problems. It persisted even though you got to the patient on the 8th day. Uh, you had this slightly increase in length of illness and the diversity of illness. And I was of the opinion that something had changed. I knew that, yes, the variant had changed, but I was of the opinion that maybe the immune response had changed from something as straightforward as a type 1 response to something more complex like a type 3 response, where you're
Yeah.
dealing with immune complex mediated responses. So you might have immune complex forming that can form in a that distributes through your body, Philip. So it will circulate with your circulation. If that is what is the target, then when eventually the trigger happens, it'll happen in a diversity of areas. You might be able to stem the mediators that these degranulations might present with, but it'll take you a little longer to overcome the generalization of the injury it caused. It was not to a specific organ or a specific system. And I saw this progress through that area of the pandemic early on. As well, my concerns were around the spike protein being used in the vaccine. Gert, you and I have discussed that at great length as to what that might do. I think just to understand, we wanted to find the best way to negate all the mortality and morbidity in this pandemic at that point. And I had found some inroads into understanding the pathophysiology. Well, we all know about the censorship and the rest that transpired. But in trying to negate the pandemic, of course, we missed very many options in not considering prophylaxis, not considering early treatment, and not considering how that would bring us understanding of the pathophysiology, as well as in our population-based measures with lockdowns and masking and the rest. In all my experience, Philip, I have not yet seen an airborne pathogen whose primary means of transmission is not fomites. It is not through the air. Oxygen in the air, the ventilation in the air, and sunlight do not allow viruses or even bacteria to live for any length of time. Even with TB, uh, for you to pick up TB from someone that's infected with TB, they need to cough directly in your face while you're breathing in. Yes, you can extend the length of survival of that virus outside the human body by keeping a room where that's poorly ventilated, maybe more humid, so that it can survive a length of time. But the majority of patients infected by airborne respiratory pathogens happen through fomites. You shake someone's hand, it lives for longer because you have moisture on your skin, and you touch your nose and you pick it up. Now, looking at the vaccine, they used the wrong thing. Why would you use spike protein? You are using a very highly mutagenic part of the virus that has the propensity to stimulate quite a great immune response to that person. And that is the most toxic part of the virus. Yes, I did understand that there was a genetic propensity in who was being affected. That tied in with my understanding of an immunologic response, because immunologic responses are tied into your genetics. Fathers and sons seem to be allergic to the same kind of things, that kind of thing. But also, that immunologic response, besides being a genetic response, is also dependent on your exposures through your life and how you develop tolerance to your environment and how you develop resistance to infection. And those two vital, important responses of your immunity will determine your viability to survive and your ability to thrive in your environment, and are the two most important factors in life. And so I was under the impression that this was triggering some kind of immune response. And there's a broad diversity of different kinds of immune response, and it was triggering some kind of immune response that was causing all the mortality and morbidity. I understood through the censorship and my trying to influence what happened with COVID, I understood clearly that there's a nefarious agenda. Philip, I'm in genetics from the 80s. I understand what biowarfare means. I understand exactly the latitudes and possibilities that exist with such platforms and what those possibilities actually are. I understand how we can use immunology and our responses to things because remember, in the design of weaponry, you want it to be discrete and discriminate. Otherwise, it's of no use to anyone. Now, when I look at what's transpired, these are the things that have sat at the back of my head from the start of the pandemic. It has led us into understanding a lot of the pathophysiology around the pandemic. Uh, we've also gone into understanding the way this virus exhibits bacteriophage activity with our looking at stool samples. It's taken us to the point where we understand the toxin production by these bacteria and how our microbiome is being targeted. And that is another means of causing mortality and morbidity. We've had many, many discussions out there about graphene oxide and all these other things that are considered conspiracy theories that I would not just pass by, get ethical people to investigate. We've had many discussions about the unusual post-mortem clots that embalmers were finding, and we now find that these are happening ante-mortemly, but luckily confined to those who took the vaccine, so likely to be related to one of the constituents of the vaccine. That gives us at least a direction to look at to figure out where the problems lie. But in totality, from my experience over these 4 years of COVID, this is what I've seen. And to end it all, I've seen the new variants. They are not that virulent, but they are far more contagious. And I'm seeing my patients getting them. I'm seeing some of my vaccinated patients trigger storms with either an exposure to a cold or a flu, or taking the flu vaccine. Those kind of triggering events seem to be very unpredictable. But understanding that they are inappropriate cytokine responses, I think I have a fair handle on how to negate them for now and how to treat them. And that extends to treating long COVID patients and vaccine injured patients as the understanding of the underlying mechanism that's causing these problems with these patients. And so
I want
that's
to
where I
pause it
am.
here. I want to pause it here a minute, Shankara, because I'm just listening to you, and I want to make the audience aware of something. People change after a near-death experience, and listening to how frank and to the point you are now, you are a man on a mission with saying that, listen, I have something to say. I have something important to give, and nobody's going to stop me. I can just feel it coming through, that very clear focus that you're not afraid to speak because you already came that close. Is that about right?
I'd say, Philip, what I'm saying, I've been saying from the start of the pandemic. Uh, I've been ignored, I've been censored, I've been banned, I've been ridiculed. I understand this is new science. I understand that it's a new perspective to science, but I place my faith and my conviction in the patterns I've studied all my life in nature around me. And that is my grounding, that I see these patterns and I cannot take them for granted, and I understand the processes. Uh, we've come out with this vaccine, just to put some context there. I'm of the opinion that, well, we're dealing with an inappropriate immune response to a pathogenic protein. There are many ways to attack that protein. We've addressed many toxins in our lives, in the way we treat tetanus, in the way we treat rabies with anti-rabies toxoids. We've known how to address these things when they occur. I'm not talking prophylactic measures, Philip. I'm talking if we realize an inappropriate trigger that's going to cause the production of antibodies that will have implication in the future, then we know how to negate that when the event happens, like how we negate erythroblastosis fetalis by checking the blood groups of patients before they deliver, and understanding that that mixing of blood, that little mixing of blood during delivery, might impact on the next pregnancy. And so we make sure that patient gets an antibody injection so that if any are formed, we negate it. Now, that's an intervention that can only occur if you can predict a point in time where that's going to happen. Cannot be done prophylactically, and it cannot be done therapeutically once the event has been triggered. Then, once the event is triggered itself being an inappropriate immune response, there's nothing hard about shutting down that response and being considerate of the type of mediators and clearing those mediators, as well looking at the different systems that were put into place. Now, where my gravest concern lies is that my understanding of nature and the balances that nature bring to us is something that should never be touched. And I'm uh, really not considerate of things like climate change and the rest. I don't think we are that important to this planet because I've seen the power of nature and its ability to cause balance and rectify that balance that's supposed to be there. So I know that nature will bring back this balance. But in saying that, Philip, a lot of my study has taken me to understand, and where I think there's a paucity of information, is to understand the interaction between all these players and the equilibriums at play. A randomized clinical trial just tells you about one medication. We need to know how things interact with each other, how they enhance each other, how they suppress each other. All these minute interactions are of vital importance. One of the subjects that I've studied quite intensively is called population genetics, and that looks at the interaction of different species and how nature grows or suppresses different species dependent on the resources that are prevalent at that time and maintains a balance. Now, we have a lot of game reserves in South Africa with a large diversity of species, and we have people that settled around these game reserves that are dependent on hunting these endangered species for their livelihoods. And we went through intensive look at how to balance this. And what we did was we created a game reserve where it was fenced. There were deliberate gaps in the fence, and these gaps were spaced exactly where the settlements were, close to where people had inhabited the place. And we made a deal with all the people around to say we expect nature to balance whatever's in this game reserve. If there are too many herbivores, then there will be flourishing of carnivores, and each thing will balance itself out. But the one thing that is limiting is the availability of resource. And as soon as resource becomes unavailable, you will get the population that's starved of that particular resource migrate out of those gaps in the fence, looking for more resource. And you are allowed to kill any animal that walks out the gap in that fence and use it for your economic gain. And we found a great balance between that. We did look at species diversity and how to maintain species diversity. But what that taught me, Philip, was that even the slightest influence on the genetic species diversity of a population is an extinction wide event.
Yeah.
And
So
what has
let's
happened to people around us, I don't think humanity understands the gravity of what stands before us when we talk of biotechnical research, no matter
yeah,
what it is.
absolutely. So now let's go to the meat of the matter. Okay. Now I want to just analyze what happened with you and let's see if we can make some clinical sense of it.
Okay.
Taking it back, this is how I usually start. When did you first start feeling unwell? About how long ago was that?
Well, that was, let's say, about 4 weeks ago, Philip. I'll take you through the look. I was corporate
Start with the
mentored
first
through the
symptoms. First
yeah,
symptoms.
yeah, yeah,
Yeah, go ahead. What
yeah.
happened?
It was. I'll tell you very clearly. It was a Sunday. I was doing some work in my practice, and by that evening, I had developed some nasal congestion. Of course, I thought it might be exposure to the dust and the rest. I was doing some cleaning, and you know. And by Monday morning, I had developed body aches and pains and a low grade fever. So immediately I knew it was an infection, right? But the sinusitis that I had developed was completely dry, unusual, completely dry. I could feel the congestion, but there was absolutely no production to it. Uh, I had this low, strange, low grade headache. It seemed very unusual. And besides the generalized body aches and pains and fever, there was nothing else wrong.
I'm
That
just
was on.
checking. What about smell and taste?
I did on the second day, Philip. That was the Sunday I noticed. Monday I knew I had an infection.
Hmm.
Sunday being my first day. By Tuesday, I had noticed that my taste had been altered a little. I could smell things, but food didn't just taste the way it did. Especially as again a slight bitterness to things. You know, anything that had a bit of spice had a bitter aftertaste. That kind of thing. That was by the Tuesday itself. By Wednesday, the fever had broke. The body aches and pains had started to subside. Remember through this period, Philip, for the Monday, Tuesday, and Wednesday, I wasn't at work. I had a locum working for me, trying to just diversify my practice a bit. And so at least I had someone to take over those 3 days. By Wednesday, the fever had broke. Uh, the body aches and pains had subsided. I felt a world better. But the nasal congestion and the dull headache remained. Right? They remained, but I had no other symptoms. And I kept
So,
thinking to myself, this is a very unusual, feels very unusual. On the Thursday, Friday, and Saturday, I was actually back at work. I had no fever. I had no constitutional symptoms. I just had the slight burning in my nose and the slight dull headache, and I kept hydrating, thinking, it'll pass. Uh, that was the Thursday, Friday, and the Saturday. Uneventful, really. On the Sunday, I had some work to do, 40 k's away. So I had to go do some shopping, household chores. And on the way back, walking from the store to my car, this headache gave me a slight muzziness, I'd say. They talk about brain fog. I couldn't
mm,
call it brain fog, but I had this slight feeling. And as I started walking towards my car, Philip, I started to notice I'm getting double visioned.
okay, pause
Strangely
there a
double visioned.
second. So when you say double vision, so you mean that vertical, horizontal, or was it any difference? It's
It
just
was it was horizontal double vision,
yeah.
but it could be negated with concentration and focus.
And what about, and I guess if you covered any of the eyes, it disappeared. You were seeing
Yeah,
normally
it
out of both
disappeared.
eyes.
Yeah, when I covered my eye, it disappeared, but there was still a not normal, slight blurriness, right?
Mm,
Slight blurriness of vision, and it wasn't constant. It occurred, and when I blinked, and it went away, right? It happened, I'd say, 3 times, but for a period of a few seconds. So it happened and then just disappeared. So it wasn't, yeah, it was a concern, but not a grave concern. I was
I'm just
corpus
curious,
mentis.
any change with the headache at that time, or was it the same?
It just remained the same. It just
Remained same.
remained the same, that was there. And then I drove back home, Philip. I got home. Uh, I at that time, remember, during this week, Philip, I was on hydroxychloroquine and zinc. I was taking antihistamines just to. I didn't see the need. My nose was dry, but I thought, hey, God put this in front of you. Don't question it. And so I took it. And then on that Thursday, before this happened on Sunday, that Thursday during the week, I stopped by the lab. I did my CRPs, interleukins, D dimers, just to see everything's in order. Everything seemed absolutely normal. My D dimer at the time was 421. Below 500 is considered normal. So I was happy with that. And on the Sunday when this happened, and I came back home, and it was strange, it dawned on me, but I don't think with the appropriate gravity, Philip, for someone that's at the front. I think doctors are the worst patients. Uh, but yeah, it dawned on me that it was my eighth day,
Hmm.
and I was getting double vision. And in the Omicron wave, where I had a reaction, on the eighth day, I started feeling strange. And on the ninth day, it triggered a widespread disseminated intravascular microcoagulopathy.
Wait,
And
hold on.
that's
You're giving us a diagnosis. Give us the symptoms first.
well, at that point, Philip, I collapsed,
All right,
suddenly
hold on.
collapsed.
So this is on the Monday.
This is not this time. This is not this time. This was the first time this happened 2 years ago when I had
Okay.
Omicron, right? I had
Okay, so
Omicron.
you had so take me through this. I didn't realize that. So when you had Omicron,
Yeah.
eighth day you
That's when
had
I
the
let my guard
sign
down and
response.
stopped sterilizing my hands after every damn patient. I let my guard down and I picked up Omicron.
And
Went through the
so
worst,
so
right?
just take me through that. That's important. So two
Well,
years ago,
Omicron,
yeah,
yeah, Omicron, exactly the same kind of symptoms. The
yeah,
sinus inflammation was far worse, still dry, but far more burning, discomforting, all that kind of thing during that week.
yeah.
Again, exactly on the eighth day, on at that time, exactly on the eighth day, I was improving. Exactly on the eighth day, suddenly, I lost my smell and taste. Just
Mhm.
suddenly. And I wondered, how come did I suddenly lose my smell and taste? And then it dawned on me, hey, it's your eighth day. But I disregarded it, Philip. I said, it's your eighth day. It's not that bad. Ah, you know, the next day, and I started prednisone, thinking, well, you caught the tap before anything happened, and you'll treat it accordingly. Because I knew how to, manage it along the way. And I took some prednisone on that day. The following day, felt fine, didn't do any bloods. Decided, well, I need to be back at work on Monday. So I took a brisk walk, which is the worst thing to do if you're suspicious of microvascular coagulopathy. I came back, sat at my desk, and my son was with me. I lost consciousness. He said it looks like I went into complete spasm. It took a few minutes for me to start breathing again. He said they kept checking and I had a pulse, but I was completely unconscious and I had stopped breathing. When I got my breathing back, I regained my consciousness, and it was like absolutely nothing had happened. I was completely lucid. I kept saying, "No, you're lying." When they were telling me what happened, I said, "No, you're lying. I'm
So,
lying."
let me get this right. This was 2 years ago.
This was 2 years ago.
Two years
My
ago,
family
and you
insisted
didn't have any further events after that.
nothing. I was
No.
I my family insisted I go to hospital and have my bloods rechecked. Everything came out normal besides my D dimer, which was normal before, and it went up from 400 and something to about 900 and something. So I
Yeah.
was given heparin. I made sure I asked them to check my platelets so that I don't end up with, we talk about disseminated intravascular coagulopathy causing thrombocytopenia. And when you anticoagulate that patient, they're going to have a bleed and they'll probably die of a hemorrhagic stroke. And we saw a lot of that during COVID. We're trying to anticoagulate patients with heparin. So I had my concerns. Within that very day, they gave me heparin. The very next day, my D-dimer had restored back to normal. I was corpus mentis. And of course, I was being terrified of injected or probed or swabbed while I'm asleep. So I said, look, I'm feeling fine. I'm going home. So at that event, Philip, I had spent one night in hospital. But I was out of the woods and I recovered completely and I was back to work in no time. And I
Excellent. So,
understood clearly what it meant. But
okay.
what that cemented, Philip,
Yes, go ahead. Yeah.
what that cemented in my mind was the importance of that 8 day.
Yeah.
I distinctly saw the change. I
Okay. So
suddenly
let
lost my smell and taste, and it had consequence that me as a doctor, understanding my state of health, didn't even notice it or predict it.
Okay. So let's pull it
Right?
back
Because
now.
it was a silent issue, you
So
know?
let's pull it back now. So we have that background 2 years ago. We come
Yeah,
around to this time. So this is now still about 3 weeks ago.
yeah,
You
yeah.
had the episode of Double Vision on the Sunday.
Right.
You were then
Yes.
fine for the rest of the Sunday.
Yeah, I came home. I was fine. I had dinner. I just had the slight thing going on, and I thought
Mm.
maybe it's my sinuses or uh,
Yeah.
headiness, maybe the sedation of the medication I'm taking,
Mm.
that kind of thing. But the things that I was aware of, Philip, was that in that first episode, it targeted coagulopathy. I was seeing this with patients, Philip, where when a patient had COVID and it attacked their lungs. Now, when we're getting the new variants, if they have a cytokine response, be it to a COVID variant, an influenza variant, a vaccine, whatever the cytokine response might be, it seems to be the same as it was with the initial cytokine response. So there's a system propensity, you know, and that seems to be different with different people. That's the reason I was speaking about blood groups, major histocompatibility complexes. How do we form antibodies? Those kind of things. Now, yeah, so I got home that evening and I went to bed that night, and a lot of it is a blur. A lot of it very lucid in between. So I had periods where I was completely unconscious, and I had periods in between where I was perfectly lucid. Knew exactly where I was, what day it was, where I was. I just missed that period. that happened.
Was
And
that
what
something
transpired,
like a seizure then? Because not
well,
many
Philip, it
things will make
changed,
you lose
it
consciousness.
evolved.
Uh,
Yeah, it happened three times in a period of about 20 hours. The first one occurred that Sunday night in the middle of the night. According to my wife, she heard me scream. She thought it was a nightmare or something like that, and she just shook me awake. When she shook me, I was quiet, and she thought, well, I woke up and then she turned to look at me, and I had my hands across my chest. Uh, I was unconscious, and I wasn't breathing. And she checked my pulse, and my son came in and they started doing pulmonary resus. I think after about a minute I regained consciousness, but in that consciousness I was lucid but confused. I was talking logic, everything was logic, but I was in the wrong place. My wife said I wanted to examine her, and in that few minutes, and then suddenly after a minute or two of being in that state, I regained complete consciousness, and I refused to believe what happened. I said, "No, I'm fine. What are you guys talking about?" You know?
mm.
And they
So
watched
that,
me.
that does sound as
I
though it could be one
blood
of those
pressure,
post-ictal
passing
periods.
event.
Yeah.
Yeah. So I checked my blood pressure, and I was looking for a post-ictal period. I had no lack of memory, any focal neurologic deficit, anything. And when I questioned my son at that time, he said that it looked like your spine went into a complete spasm. The spasm was so great that you couldn't take a breath and you lost consciousness, right?
Mm.
The
Was that
minute
when
the
you were
spasm
admitted to
stopped,
hospital?
yeah, the minute the spasm stopped, Philip, I managed to start breathing again, and then I regained my consciousness and lucidity. My family, look, I can be a stubborn person, and yeah, my son and wife sat there, and I said, look, it's a transient thing. This happened before. I know it targets my red blood cells. So right there when this happened, I took 50 milligrams of prednisone, and I took an aspirin and a colchicine. And I said, look, I know how to treat this. Let's just be on the side of caution. Tomorrow morning, first thing Monday morning, I'll go back to the lab, I'll repeat my bloods, and I'll know where I need to act on this, right? But with the understanding, Philip, that in the first wave, it targeted my red blood cells, right? And
Mhm.
triggered the coagulopathy, right? Uh, at that point, they watched me through the night. I was fine. I got up that morning, had a cup of coffee. I was getting ready to get started with. I had a meeting with some of the doctors working for me, and I went upstairs. And my son said he was standing next to me. He saw me turn. He could see that I wasn't there. I turned. Again, I went into that tonic spinal spasm. In that state of spasm, Philip, I stopped breathing. I was not conscious at that time, but I was lying there in a absolute tonic spasm, which he looked at as a seizure. He said, "Dad, that was a seizure." That second episode, Philip, they couldn't get me out of. They called the paramedics in. The paramedics eventually managed to resuscitate me, and they rushed me to ICU. When we got to emergency, I had fully regained consciousness by then, and I knew exactly where I was back then. Again, denying everything that happened to me and saying, "No, no, you're talking nonsense. I was a small thing, you know." But luckily, during that period of lucidity, well, you can imagine everyone running around me, Philip. But I had the Dr. Vishal Maraj, the specialist physician there, and he asked me what I think, and I gave him a run up like I did you as to where this happened. I said, "Look, I think it's my intravascular coagulopathy. Please do my D dimer. I think that this has suddenly triggered a broad, diverse intravascular coagulation, and it happened very suddenly. And I think that's where the rub is." And I explained my work to him and why well, the controversy, Philip. But at
Yes.
least they respect the work that I'm doing and understand it. So I explained to him, this is what I suspect it is, and it seems to be central, affecting the area of my brain stem. because it seemed to have caused my entire core to go into spasm. There wasn't so much of peripheral spasm. There was no focal deficit. There was absolutely nothing to show a typical seizure activity or a typical focal lesion that could trigger a seizure. So I put all this on the table with them and said, look, this is what I think is happening to me. You know, triggered a microvascular coagulopathy. It showed up in the smallest vessels in my body, in my eyes, in my retina, and started showing up with this crossing of my vision and my eyes trying to accommodate something. And there suddenly I lose consciousness, and in the strangest of way, with the spasm, in the strangest of way, they sat there scratching their heads, Philip. Uh, they, at that point where we discussed everything, Philip, at that point I had the third episode. In that third episode, they witnessed it. They were at that point wanting to transfer me to a high care cardiac facility because they felt it might be a cardiac issue they're dealing with. But
Mm.
I discussed it to them and I said, look, this is neurology. Please listen to what I'm saying. This is disseminated intravascular coagulopathy. We are seeing microvascular clots with COVID, and it can be a very simple target, right? So they kept me there. We, when I had that the third episode, they witnessed it. That was a very bad episode that needed, I coded, it needed resus. So that Monday, I was admitted unconscious into ICU. I spent the entirety of Monday and Tuesday unconscious in ICU. In that period, Philip, they did every possible test. I'm thankful that they listened to me, followed my instructions. I said the first thing you do is an angiogram. Yes, you don't want to put me on anticoagulation. I understand your reservations, but I'm telling you this is a coagulation event. So the first thing you need to do is rule out a bleed and put me onto anticoagulation.
Hold on.
The
Was there a
only
second?
thing,
Was there,
just to fill in there, Philip. When I went in conscious, they ran every blood test in the book, right? My kidney function, my liver function, the whole truth. I said, but you make sure you run an IL-6, the D dimer, and the CRP. And I'm
yeah.
telling you, that's going to give us our diagnosis. Every single test that they ran, Philip, came out normal, absolutely normal, right? My D dimer had gone from 421 to 6,000 overnight.
Mm.
And that's the reason, and I said enalapril. Besides enalapril being an appropriate anticoagulant, it is also an antibody almost to spike protein. It has
Enalapril, you said, or heparin.
yeah, heparin,
Heparin. Yeah.
heparin, heparin,
Heparin.
yeah.
Yeah. So you
Heparin.
wanted now.
That's
So
right.
let me just
Injectable
clarify
heparin.
something. Yeah. So let me clarify something here.
So
Are
I
we
told them, I
talking?
said, look, injectable heparin for
Yeah.
now. If not, you're worried about my platelets? Xarelto, rivaroxaban. It works.
Okay. Pause here a second. Was this intravenous heparin or low molecular weight heparin? Any difference?
No, it was subcutaneous heparin.
Subcutaneous. So low molecular weight heparin.
Uh,
Okay.
But I explained to them that I'd taken a colchicine, I'd taken an aspirin. I understand it's a clotting event. I do understand the risk I took by taking that, but I do understand the history I go through and the experience I've had. So I put that on the table. I said, you do my FBC and check my platelets. You do an angiogram of my brain. If there is absolutely no bleeding event, you actively anticoagulate me to get my D dimer back to normal. Then I had that other seizure. They resuscitated me. They did exactly what I'd asked for. They stuck me into ICU. They started the anticoagulation. I spent the entire Monday unconscious in ICU. I was hooked up to a 24-hour Holter. They had done an echo on my heart. They sent me for a coronary angiogram to make sure there's nothing wrong there. They hooked me up to EEG, to a constant EEG. They did everything they needed to, Philip, in every single thing, Philip, through that entire investigation. They were looking for a cause. By the Tuesday, I had started having lucid intervals. I could remember friends or family coming in to try and feed me. By the Wednesday, I had regained complete consciousness. I'd spoken to the doctor. I'd started to review my blood tests and what happened. By the Thursday, I had insisted I want to be discharged. But what transpired as well, Philip, in that time that I think was important, besides me directing them into what needed to get done, the Tuesday I started to regain consciousness, and in that regaining of my consciousness, I was completely lucid. I knew exactly what had happened to me. I could, understand the completeness of what was there. All of them were scratching their heads simply because they had done every single test in the book, from a cerebral to a coronary, MRI angiogram, an ultrasound of everything, all the relevant blood tests, everything they could think of, besides a gastro or a colonoscope. If they tried a colonoscope, I guess I would have regained consciousness a lot quicker. So thank God for that. But in all that, Philip, in all that, they did a drugs of abuse screen. They did toxicology. They found absolutely nothing besides a raised D dimer.
So, quick question: what
Absolutely
happened
nothing.
to the IL-6? Was the IL-6 normal and the CRP?
IL-6 was normal, CRP was normal. Now, if I say IL-6 and CRP being normal, let's put that into context. When I had that first episode at home, I took a Phenergan, I took 10 prednisone, and I took an ecotrininol colchicine. So that must remember that reflects the effect of those medications. That might have been sufficient to suppress my CRP and IL-6 because I've seen those kind of quick recoveries, but not good enough for the response I had with the clotting issues.
You
And
know,
so, yeah,
I
on
need
the
to
Thursday,
mention.
yeah,
Mhm.
just one other thing, Philip. On the Thursday, I insisted to be discharged from hospital. The only thing that had happened while this occurred, uh, in the during the seizure activity, the intensity of the muscular spasm down my central spine had caused a fracture of the vertebral body of my T8 vertebra. And so I fractured my T8 vertebra somewhere along this episode. Luckily, with the fracture, it was a compression fracture of the body, and there was no impaction into the spinal canal or any affectation to the nerves, impingement of nerves that surround the area. So I would call it completely recovered, but
So,
for a T8 spinal fracture that needs to be nursed back into health. So
excellent.
yeah, I deal
This is
with intense pain, but I think I can handle that.
no, this is
Sometimes
important information,
teaching
Shankar.
experience.
Yeah. So let's just dissect something here, because this is where it becomes very relevant to, just in case there are clinicians who are listening. The first thing that you seem to have identified is that this is brain stem. And I can say clinically as well that I have noticed that when some patients deteriorate, it appears to be brainstem involvement, that they may get uncoordinated, they can become semi-comatose, and that has puzzled me. But what you're saying here is seeming to align with what I think could be happening. Now, the bit that I'm trying to understand is what is driving it. So I was doing some research before, trying to piece it together. And I realized that mast cell activity certainly can occur. But the mast cells are not really in the brain, but they're in the meninges, they're in the choroid plexus, and they can release histamine, which can then cause these kinds of strange responses in the
Yeah,
brain.
yeah,
But what has stood out to me here is the fact that the only therapy that reversed this was low molecular weight heparin.
yeah.
Now
Look,
that,
Philip, the way I look at that, Philip, yes, I got to try and make understanding of what's happened. Uh, when we got to Omicron, and I was seeing the patterns of the different variants in the systems that they influenced, I had predicted that Omicron is going to affect our nervous system. And of course, we saw that. And we saw the way it affected it. It could affect your nervous system from a broad, diverse peripheral neuropathy to a very focused neuropathy, tinnitus, numbness in one arm, very focal kind of neuropathies, to very central kind of neuropathies that mimicked diseases like Alzheimer's and dementia and acute psychosis and those kind of things. Now, I've been unfortunate enough to treat such patients. Uh, and in doing so, Philip, some of them very close to me, family members. It brought a few things into stark perspective. Just to put just two simple cases, I had a family member on the eighth day start to become aggressive. By about the 14th day, he had now been hospitalized with acute psychosis. And by the 14th day, they were going to discharge him into a psychiatric facility. I asked his wife to bring him home. I said, look, that's a mast cell deactivation in his brain, and it's caused a histamine release, and it presents as acute psychosis. So I stopped all his medication on the Thursday. By the Saturday, I thought it safe enough to institute my modality of treatment, which is about stabilizing mast cells and mopping up histamine and the chemical mediators. And by the following Tuesday, I had a 2 hour conversation with him. He had returned to absolutely normal. This has been 2 years ago. That was a misdiagnosis that could have cost him his life. My dad got out of hospital, had a knee injury, was recuperating with a cousin. I got a call a Sunday morning to say for the last 4 days he doesn't know where he is. He's wetting himself, trying to jump out the window. So I rushed off to Pietermaritzburg. On examining him as well, Philip, no focal neural deficits, no typical pictures that you'd see with Alzheimer's or dementia. Yes, it looked like senility, but senility to creep in over 4 days is highly unusual. These are not the way neurologic conditions present. There's got to be some initiating event. And so I looked at him and I thought, did this man have COVID and is he having a reaction that's triggering this? So I drew his interleukin 6, his D dimers, and his CRPs. And on the way home, I dropped it off at the lab. By the next morning, I got the results, and all of them were sky high. He was having a cytokine reaction to something. I immediately started him on the medication that I thought necessary to calm it down. That was on the Monday. By the Thursday, he was completely back to his old self, knew where he was, and could sit and discuss the politics of the country with me. He would have been put away as a patient that had developed senility and left as a lost cause. Now, these are the things we're seeing going on around us. And so I understand the diversity of what we face. And from me going to hospital, Philip, from me finding a way through this, from me understanding how quickly it took me, from me understanding that prophylaxis really didn't save my life. I understand, and this is where I feel the virus and the vaccine in the way they were designed. Uh, every exposure to the virus in an unvaccinated patient leaves you at risk of being sensitized by the spike protein. And that sensitization can occur in any tissue in your body. And I think that that tissue is determined by some genetic predisposition, blood groups, histocompatibility complexes, exposures through your life, your tolerance to your environment, those kind of things. That kind of exposure is with the virus, hopefully transient, but with the vaccine, it is an exposure that again is targeted and will be dependent on your genetic constitution as to which organs actually get targeted. Remember, Philip, we know the biodistributions throughout the body, but biodistribution is one thing. Incorporation into a cell membrane is something else. Let's not even get into the contaminants that we saw in the vaccine and the poor marketing of it and the way it was not transported accordingly and what comes with that. But if you just look at the RNA and what it was meant to do in creating spike protein and us understanding its biodistribution, Philip, you and I from the start been talking about spike protein being a membrane protein. And if the body makes this protein, it will get incorporated into the cell membranes of the cells that make this. Now, of course, I think that there's a genetic predisposition into which cells manufacture spike, because in some people it's renal tissue, and in some people it's cardiac tissue, and so we're finding spike in a lot of different tissues. but not necessarily everywhere. So I think the ability to incorporate spike into your tissue has a genetic predisposition. But what that actually does is it primes different people in different ways. So we're sitting with a population where some are primed, some have their livers primed, and some have their kidneys primed, and some have their hearts primed, and some have their neurology primed by their exposure to this single toxin, spike protein. Now, if you have a population like that that's primed, then a virus with a very specific spike protein can act as a very effective, discrete, and discriminate trigger for the population you wish to target in the next
You know,
pandemic.
I want you to think about something here, Shankar. This is very important, and a lot of people don't get this. And it's because I look for it why I see it. A lot of people don't even know when they were infected because
Yeah,
sometimes symptoms are so mild that they just ignore them. And then 3, 4 weeks later, they have significant pathology. As you say, it could be kidney, it could be heart, it could be brain, whatever. And I have noticed from a clinical point of view that if you go back carefully and you look for that prodrome, you usually find it. And so
yeah,
you're right in the sense that there is a time delay between the exposure to the spike and the manifestations of disease. And very
yeah.
easily, people will not connect the two.
They
Unlike,
won't connect the two, Philip. They will be discrete. They will be discriminate. And so even if you have a pathogen that spreads, if we have a pathogen that liberates a certain variant of spike protein, and that variant of spike protein triggers an autoimmune response to people who have developed receptors on a particular organ system. So let's say your blood or your vessels, then that particular variant will trigger all the people that were primed in that way. And so we'll have a similar disease with a group of people presenting with hemorrhagic coagulopathy kind of illnesses. And that would tie in with what we would be sold as a new variant causing hemorrhagic problems. So yeah, it's not indiscriminate. They can group it together. But I think it's time we realize we've been primed. In one of the interviews we spoke about, Philip, I mentioned that I'm of the opinion that they've changed the physiology of the entire planet. And what I mean by that is how we respond to the things around us. And what allows us to survive and thrive is our ability to tolerate our unique environments and our ability to resist the pathogens that might influence us in that environment. And it's a balancing act our immunity is more than adapted to take care of. It's the reason we thrive. It's the reason for our existence. Now, the fact that this has happened, and the fact that I am of the opinion that the root of the problem lies in the understanding of immunity or our lack of understanding of how the different immune mechanisms interplay with each other. And this is occurring throughout nature, Philip. It's balancing everything around me. And our lack of understanding, and more importantly, the understanding of certain people with nefarious agendas of how this works and using it to suppress certain information and use certain knowledge for the wrong means. We are at a place in humanity where we face an existential threat that is absolutely invisible, but it's an existential threat. And we have to figure ways to identify how people have been put at risk. Because let me tell you, uh, if I did not mention to the doctors disseminated intravascular coagulopathy, my D dimers, my concern about microvascular clotting, this being my eighth day, understanding how it triggers it, how this will spiral out of control before they actually understand the pathology, that there are certain things they can do without having to think about it. Rule out hemorrhage, anticoagulate me, deal with the rest as you see fit, you know? And I think it was that little bit of advice that saved my life. It saved my life. And I think it made me stop and redirect, re understand. So now, with my understanding, Philip, you must remember when it comes to immunity, we can talk about immune priming, we can talk about immune suppression. But one thing we must never forget, we should also talk about immune labeling. They can use viruses and vaccines to label us accordingly, label the target before you release the weapon, and use the genetics of the individual to specifically label the targets you wish. You're using our genetic predispositions against us. Uh, so the variants, the vaccine, all these kind of things can act as priming, and for them to release the appropriate trigger whenever they feel it absolutely necessary. But I think, Philip, I understand it's a spiritual war. I've mentioned this to you many times. Everything that's happened to me along the journey, I think, was meant to happen, meant for me to understand, use the knowledge I'm blessed with to gain understanding, for us to use it to save lives. Uh, I do understand what humanity faces. I mean, last year I did a pilgrimage to Mount Kailash to sit in front of God and figure out where we're going. It's something I think is vitally important. Uh, I know we'll not solve this problem on our own. We might be given insight into what's happening around us. I think for the moment, humanity hasn't yet come to grasp with the gravity of what faces us. Uh, we are at the brink of extinction, and we're still far from understanding how that's going to happen. But a simple understanding of the nefarious agenda, how immunology works, how we can be targeted, how they've actually targeted us, will bring us solutions. And I'm sure if we can cure things like erythroblastosis fetalis, snake venom poisonings, things like tetanus toxoids, and how to negate that, I think humanity has great potential. And I'm sure we'll solve the problem if you understand the problem and and simply accept the extent of it. Underestimate it at your own peril. And so I prefer overestimating it and being prepared. And so this has been a teaching experience for me.
Just in case people listening don't understand this, I know listening to Shankara that this is somebody who is now thinking and looking at a different level. And so, what he says, even though it may be controversial, and I may have to clip out bits on certain channels because they won't like it, but what he is saying is coming from somebody who has just been right to the edge and has come back with a message. And it gives us hope, Shankara, because I think that that one thing, just in case there are any clinicians floating around, that one thing about heparin, I didn't realize until I started to research it a bit that heparin also stabilizes mast cells. It's anti-inflammatory as well as it's anticoagulant. And it was used certainly in the cytokine storm, but if they used it too late, you can't negate
Yeah,
it
they
with
trigger
heparin
bleeding.
on its own.
If you allow
You
the
know,
coagulation to take place, the platelets get mopped up, and eventually, when you decide to use a heparin, you trigger bleeding. And so
yes.
once platelets count goes down, you got to go to mechanisms or modalities that don't have that as a risk factor, like your rivaroxaban and that kind of thing. Yeah, Philip, it's been a crazy journey. Yeah, I do know I came to the edge of my life, but mind you, I think you know me. It's not the first time. I challenge the boundaries. It isn't my job to keep me alive. Strangely, Philip. My mum and one of my dad's uncles, both of them came to me at the end of their lives to help me see them to their demise. And I helped them through that. It caused a lot of controversy in my family. But somewhere in that period, I saw my mum and my uncle. They were in good health. They didn't speak to me, but they acknowledged my presence. And me being the naughty kid I was under the impression I did something wrong, and they were there to admonish me. But yeah, I'm still here. And so, yeah, I think it re-established and reinvigorated my understanding that we're not alone. We are all joined together by a common thread. And I think that common thread is love and compassion. And yeah, so it's not a war that's unwinnable.
Excellent, excellent. I can't ask for a better ending. Thank you very much, Shankara. And thank you, everyone who has been with us and saying wonderful words about him. I think that this is an important record. That's one of the important things I thought, just for people to reflect on, especially people in the clinical world. There are going to be answers that we can use. We just need to be creative, find ways, make sure we can protect as many as we can. But I think that there is something you have said. This is an existential crisis. And the implications, just as Gert had also predicted, I don't think this next year is going to be easy. It's going to be challenging, and we can only do the best we can.
Yep. And with what I've been through, I think we're a little better prepared.
Wonderful. Great. Thank you, Shankara. Just stay with me. Let me just play a quick outro. Thank you, everyone, for joining us, and look out for our next interview, hopefully coming up shortly.
Thanks, sir.